And at first, I kind of thought about that topic, and I really didn't want to focus on mistakes. That seemed very negative. So I was thinking of other things that I might want to talk about. But then, as I thought about it more, I realized that so many of my learning moments have been from a mistake. I remember when I didn't do something quite right, and I learned that for a very long time. So I decided maybe he was right. Maybe it was a pretty good thing to talk about. And so today, I chose 10 mistakes to avoid in caring for children. Many of these mistakes are one that I made myself, or that other doctors send kids to my hospital, and I've noticed that maybe something was not quite right that would have made their care better. In going through these mistakes, I hope that I can show you some of the key differences between caring for children and adults in which we can make the care for children better. So the first mistake that I say not to make is not knowing what normal is. So in a lot of the lectures we've had, in some of the PALS classes, in a lot of our lectures, we've started to talk about things like, is the child have normal vital signs? Are they eating and drinking okay? Things like that. Well, how do you know that unless you really know what normal is? And this isn't something that you need to memorize. It's something that you can look up when you have a patient in front of you. So for example, a normal neonate, a normal newborn, they might lose weight at first, and that's actually okay. But when should they start gaining it again? How often should they be feeding? How much weight should they be gaining? Those are important things to know when you have a baby in front of you, and you're trying to decide, are they okay? Can I send them back home? Or is there something going on where they might be getting sick? It's easy when they're really sick, they're lethargic, they're not moving. We know that something is wrong. But we want to pick it early and identify it early by knowing these abnormal things. Other examples of them, some things to know. So what does a normal umbilical stump look like? You want to identify something like umbilitis when it's early, that middle photo, and before it turns into a septic neonate. So every time you're examining a neonate, looking and understanding what normal looks like, so that when you see something abnormal, you can pick it. And like Dr. Ali spoke about in his presentation, that early recognition of critical illness is key to being able to treat it well. And like I said, I don't have any of this stored in my head for the most part. When I'm thinking about numbers, what is hypotension for a baby of this age? What is tachycardia at this age? I am going to find a reference that tells me. That way I know I'm looking at the right thing. So I have a pocket card when I work in the emergency department that lists normal vital signs at different ages. The Braslow tape, when there is a child in front of you, you can pull the tape, it measures how long they are, it gives you an estimated weight, it tells you normals, it tells you drug dosing. So that when I'm in my emergency department and I walk by those monitors, they're in the hallways, and I see a number, and I see something like a heart rate of 50. I then look at the computer and I see, how old is that child? If they're a teenager and their heart rate is 50, that's usually okay. If they're a 6-month-old and their heart rate is 50, I'm going into that room to see right away. So knowing normals is just one of those things you must know. Another thing is knowing what normal developmental milestones are, at least just the basics. So if you're examining a child and they're 6 months old, they should be at that stage where they're starting to sit a little bit. They should have head control. And if they don't, talking to the mom about how have they developed before this? Is this new because they are sick? Because that could be a red flag. It could let you know that something serious is happening. So that's the first one I thought of. The next one I thought of has to do with math. Who loved math in school? Who loved it? I actually really liked math. Who loved math tests in school? You loved math tests too, exams? Yeah, so some people really love math. What I don't love is trying to do math when there is a dying baby in front of me. It is hard. And in kids, drugs are dosed per kilo. And to do that math, I almost always pull out my calculator because I don't want to be doing it in my head in such a stressful situation. The other thing is that almost every drug has a different dose per kilo, and they have different maximums, and sometimes, like amoxicillin, they have different dosing and different maximums for different conditions. Like strep throat, you do 50 per kilo, otitis media, you do 80 to 90 per kilo, and they have different maximums too. So having a drug reference that allows you to look things up and make sure you are giving the right dosing and not hesitating to use a calculator to double check. Because if you make an error and you give 2 milligrams per kilogram instead of 0.2 milligrams per kilogram of something like diazepam, that's a big deal, right? So really making sure you know the dose. Another thing is not considering giving distraction and analgesia. When a baby is very, very sick, they're about to have a code, you are worried they're really septic, we do stuff really fast. But when they're a child in front of you, and they're awake, and they're looking at you, and you know you need to get an IV, maybe you need to do an EKG, maybe you need to do another procedure. If you can provide something like intranasal analgesic medicines, if you can give something like ketamine to provide some sedation, if you can play music or have some nice pictures on the wall like the PEDS emergency department at Muhimbili, if you can have an iPad or a phone with a little video on it, that can help calm that child so much and often makes your job much easier in being able to evaluate them and being able to do procedures. Another thing to think about is you always want to consider that a pediatric airway may be a very difficult airway. In adults, we often talk about big fat people with no necks and how hard they might be to intubate. And we often think of the difficult airway as somebody that is very big. But the anatomy of a child and the pediatric airway can sometimes be very difficult, and you can be a little bit surprised. So each time you go to intubate a child, you should have a backup plan of what to do if you are not able to visualize those chords in the way that you think you want to right away. Some of this is because they have a very big occiput, the back of their head is big, so when you lay them flat, their head goes down like this and their airway gets pushed down, like that top photo. So you might need to put like a little roll under their shoulders. The most narrow part of their airway is at a different area than adults, so sometimes it's very hard to pass that tube, and you'd want to make sure that you have another size available, a backup plan for this situation. Because the worst thing is to try to intubate a baby, a child, to miss and not have something else to do. Because they have almost no oxygen capacity, they get hypoxic very quickly, and then it turns into a code. That was sort of my A, B, C, D, E, thing to think about. This is the B one. When you have an asthmatic, I sometimes see very sick asthmatics in my emergency department. And a resident may examine them and say, I heard no wheezing. And they feel very reassured that there was no wheezing. But I want them to tell me that they heard breath sounds, not only no wheezing, because a silent chest is terrifying in a child with bad asthma. Because although wheezing is the hallmark of asthma, it needs two things. It needs that obstruction, the problem with asthma, and wheezing needs airflow. So if they are getting so sick with their asthma that they don't have airflow, you don't hear wheezing, you hear silence. So you want to really make sure that if someone looks like they are in distress, like this child does, they are sitting rigidly, you are seeing those muscles working, they have a look of panic in their eyes, or they are getting exhausted and tired, you want to make sure you can actually hear something and treat them. So that was my A and my B considerations. My C consideration is not recognizing signs of early shock. So the adult one is what we all think of when we think of going into shock. We think of the heart rate gets higher as you lose blood from hemorrhagic shock, and the blood pressure gets lower, and those things go together. That's how we really think about shock a lot of the time. And that's what happens in most adults. But in kids, their hearts and their blood vessels are pretty awesome. They can keep their blood pressure up, and they can keep their blood pressure normal, even if they lose like 1/3 of all of their blood. So if a child starts to get hypotensive, if they start to have hypotension with that tachycardia, and they're losing blood or becoming dehydrated, you know that they are going to fall off that curve. Hypotension is a very late finding for children, and if you see it, you need to act aggressively. My 7th one is abdominal pain. You want to be a little bit fearful of that chief complaint in a child. So this morning, we heard about cardiac syndromes in adults, STEMIs and NSTEMIs. And when I hear of an adult that has chest pain, looks a little bit not well, that makes me worried, right? Well, in children, a lot of chest pain is pretty benign, unless they have some fairly rare congenital cardiac issues. Most of them are not having a STEMI. It's not where the majority of our emergencies are. The belly is where the majority of pediatric emergencies are. And it changes by age. You can see some of the differential diagnosis that you might have in all ages. In those little babies, you might have things like midgut volvulus, pyloric stenosis, you can have Meckel's diverticulum, intussusception. As they get older, you can have appendicitis, you can have things like sickle cell crisis if they have sickle cell. And as they get even older, you then start to think about ectopic pregnancy even. So this is a place where emergencies happen in children. And sometimes if we're thinking about the adult world and they have abdominal pain and they don't look septic or awful, we don't worry as much. But it really is where a lot of bad things can happen in kids. Number 8. There are some medications that we might prescribe to families, to a parent, for example, to a grandparent. And I think our mistake is not telling those families how important it is to keep those kids away from that medication. Because there are medicines that we say a single pill can kill. These are the categories that they typically fall into: antidepressant and antipsychotic medication. A single pill of an adult dose can cause a child to have arrhythmias, seizures. They can get very sick. Heart medications, like beta blockers, can cause hypotension, can cause very low heart rate, can cause hypoglycemia, and can actually cause death. Just a single adult dose in a small enough child. Calcium channel blockers are very similar, so those are ones that you want to watch out for. Narcotic medications. We all know that they are becoming a problem more and more worldwide. But if a child gets a single dose, they could have that apnea, They could have that respiratory depression and actually have very bad outcomes. Some anti-malarial medications, quinines, they can have bad outcomes, arrhythmias, seizures. Theophylline, diabetic medications, especially the longer acting ones, can cause low blood pressure or low blood sugar in children. And then there's some topical products as well. So things that have any salicylates in them that are topical, lindane as well. Those, if ingested by children, can really have very serious outcomes. So if we have a child come to us that has ingested one of those, we want to observe them, sometimes up to 24 hours, to make sure nothing bad happens. But if we're prescribing them to a family that has children, we should also let them know it is very serious. You want to keep this somewhere where your children cannot get it. My 9th mistake is to not understand that children get different injuries than adults do. And so there's some key anatomical differences between kids and adults that makes them have some very different injury patterns. I think one of the big ones is chest injuries. And for those who were in my talk yesterday, you heard this a little bit already. But kids' bones are really elastic, pliable. They can move quite a bit without breaking. So in kids, if they have a blunt force trauma to their chest, they're in something like getting hit by a car, their chest wall will move quite a bit. It can hit their lungs quite a lot. It can cause cardiac contusions. It can cause lung contusions without breaking a rib. Whereas in adults, if they have that injury, if they have a very bad chest trauma, they're going to break a rib, they're going to get a pneumothorax, most likely they're going to have a hemothorax. It's simply a different injury pattern. If you see that a child has a contusion, a lung contusion, early after their trauma, know that that often gets worse over time. So don't be reassured by no bones broken. Look at their lungs, look how they are saturating, look how they are breathing. For abdominal injuries, kids have big organs and a relatively smaller ribs and thin abdominal walls. So their organs can get injured pretty easily, especially their spleen and their liver. If they have been hit in the stomach, it is very common for them to have those injured organs, less so in adults. For head injuries, they've got those big heads, they've got sutures, and they've got an open fontanelle when they're young, right? They've also got a less myelinated brain. So when you see a child with a head injury, they can have injuries more easily sometimes because parts of their brain are not well myelinated. And then if they do have an injury, they have a little bit of extra space in there. If they have some bleeding, if they have some swelling, they have a little bit of extra space if they have an open fontanelle. And so if they start to show signs of elevated ICP, that's pretty serious because they've already swollen outside of that extra space. So if they start to have hypertension, they start to have bradycardia associated with their head injury and their altered mental status, that is very serious. It's something where you want to get those neurosurgeons who talked earlier to come right away. Their bones are also different, so they have fractures differently. They can have a lot of different types of fractures that are not just simply broken bones, but bent bones, green stick fractures where they break on one side, torus fractures, also known as buccal fractures, where their bone just sort of pushes into itself, or plastic fractures, where their bone simply bends but does not break. Those types of fractures do best if immobilized, at least for 4 to 6 weeks most of the time. And immobilizing and ensuring the best outcomes from fractures is important because especially if it involves something like a growth plate, it can affect how that child's limb grows for the rest of their life. So there really are differences in how trauma presents in kids. And the final one is not to miss signs of child abuse. And I mention this because what we have found through research in a variety of settings is that most children who die from child abuse actually had a previous injury and were often seen by a healthcare provider for that previous injury before their death. So if we see them and they are alive and we can pick it up and help them from not being abused again, we can potentially save a life. So some examples of red flags and things to look for are bruising, where it is. So if you look at the top and the bottom, which one do you think is accidental bruising? Things that kids get from playing. Say it nice and loud. The top, right? Who has kids that are under 10? How many of them have bruises on the front of their shins, on their lower legs? Yeah. All kids pretty much get bruises there. And the places in blue are where kids get natural bruises from falling, from playing. They're very expected. The areas in red are the ones that our body tries to protect. We have fat, we have bones, we have anatomy that generally stops us from getting bruises in those places when we have just an accidental fall. So, if you hear a story and you don't understand exactly how a bruise might have happened, and it's on one of these high-risk areas, you need to think about how it happened. Some other examples of bruises that we don't expect to see are under the tongue in babies, a subungual hematoma, bruising under their tongue. It is usually a sign of forced feeding in babies, forcefully putting a bottle into their mouth. And then ear bruising, because your ears are so well protected that it's often from being yanked by the ear quite forcefully in order to cause the bruise. Burns are another thing we can see with non-accidental trauma or child abuse. And this photo isn't nice in case you want to cover your eyes, but this is a child whose legs were submerged in hot water as a punishment. And you can see they are burned in a stocking pattern. And you can imagine that that's very hard to do accidentally, because if you put your foot into hot water and it was that hot, what would you do? You'd pull it back out. So we don't see these kinds of burns accidentally. And you can see the other examples in the photo. There are also some important fracture patterns, like some long bone fractures, things that are like twisting or spiral fractures of the humerus or the femur really should be explained by a major injury. If they are happening without a clear mechanism, like a car accident, we want some explanation for that. Posterior rib fractures in babies are usually because somebody has grabbed them around the chest and squeezed so much that they have broken their posterior ribs. And metaphyseal fractures at the corner of long bones are something that you see because people shake babies, and when they shake them, their arms move so rapidly and in such disorganization that they get small corner fractures that are almost a pathognomonic sign of child abuse. It doesn't happen in almost any other condition. So you want to watch for those things, and if you see them, use all of the resources that you have available to investigate, social workers, other things that you have at your hospital to help keep that child safe. So I hope that you've gotten a few little pearls, a few things to avoid through my top 10 mistakes. So know some normals. If you don't know them in your head, get a reference to show you them. Get a calculator, do math on the calculator, and look up dosing to make sure that you are giving the right dose for pediatric patients. Give distraction, give analgesia to make your care as easy for that child and family as possible. Consider a pediatric airway to be a difficult one so that you have a plan if you cannot intubate right away. With an asthmatic, don't be reassured just because you can't hear wheezes. Make sure you can hear breath sounds. Recognize that tachycardia alone is a sign of shock in a child, and once you see a low blood pressure, you are in trouble. Worry about abdominal pain as a source of something that could be very serious and very emergent. Tell families if you are prescribing them some of these medications that could be very dangerous to their children, tell them to keep them far away from their kids. Know that in trauma, there's different anatomy that causes different injury, and educate yourself on some of those signs for child abuse, and know what you would do if you picked them in your environment to help that child. Thank you so much for your attention. And if anyone wants to contact me or has questions, that's my email. Thank you.
Thank you. Thank you, Dr. Britt, for the talk on highlight things to avoid when you're caring for pediatric patients. Actually, it's just to remind us a lot of things, and thanks for that, that it's not only you need to know what to do, but also important to know what to avoid. Thank you, Dr. Britt. So if you have questions, comments to reserve, we're going to give it time at the end of these sessions. Ladies and gentlemen, allow me to introduce the second speaker on this afternoon sessions, and this is Dr. Steve Dunlop. Dr. Steve has been introduced this morning, but just because we're coming from lunch, maybe we are a bit sleepy. Let me remind you a few things regarding Dr. Steve. He's attending physician at Hennepin Medical Center. He's associate professor of emergency medicine at University of Minnesota, but also director of fellowship in global health emergency medicine. As not enough, Dr. Steve spent a number of years in East Africa doing educational research and system development. And recently, he just came from Uganda doing the same. So, Dr. Steve, podium is yours. Thank you.
Can you guys put me up on the big screen? Hello again. For those of you guys who didn't see me this morning, I talked again. You thought you were rid of me. I did put my coat on this time. I was kind of cheating. You know, we pretend emergency physicians don't dress up. That's the whole point of being an emergency physician. So we come to these conferences and put it on. So I couldn't do it anymore. So Mabula asked me to talk about status. This is not something that I am an expert or love, but it is something that we can talk about, and hopefully it'll be something interesting for you to talk about. So let's do it. What do I do now? We've got status, we've got refractory convulsive status. So we're going to talk about what it is, we'll talk a little bit about why it happens, and then we'll discuss what we do to treat it. So that gives you a little understanding of where we're going to go today. The definition from the International League Against Epilepsy they have as a seizure is sort of a sudden uncontrolled electrical disturbance in the brain that can cause changes in behavior, movements, feelings, and level of consciousness resulting from abnormal electrical activity. So seizure. Okay, so what's a status? Status seizure, originally defined as an episode that's greater than 30 minutes or 2 episodes within 30 minutes without return to baseline. That was sort of the traditional diagnosis of status. But, you know, emergency medicine's reaction to a 30-minute seizure, I mean, there's just no way, right? Like, there's no way I'm going to sit around and look and watch a status before I say, I'm going to watch the clock and wait to hit 30 minutes. Okay, now it's a status seizure. Let's just be a little more aggressive now, right? It just doesn't make any sense. And so, no, we don't wait 30 minutes, and there's more of an operational definition of status seizure. And if you look in the definitions now, there is a more updated version of what status is, which is a seizure once you get above 5 minutes, or 2 seizures without return to consciousness in between. So when you have that situation, you would consider that a status seizure and something that you want to be more aggressive about. Of course, there's a lot more in sort of seizures 101, right? And we're kind of skipping basic seizure, and he's got me straight into status seizure. But part of that would be, why did they seize? Is it a first-time seizure? Do they need to do a first-time seizure workup? Are they typically on seizure medicines? All those sorts of things that we might think about. And we're kind of skipping a little bit. So what is refractory status then? And that was the topic that I was given by Peter. So refractory, so we've got status, our seizure that's 30 minutes, or actually anything basically over 5 minutes. Or just as anyone want to yell at me, how long, 90% of seizures will self-terminate in how long? Like on average, when you see a seizure, how long do they last? Yeah, it's short. 90% will self-terminate within 2 minutes. Right? And that's really important to know, because when someone has a seizure, what happens? The nurse comes screaming and, blah, blah, there's a seizure, and you come screaming into the room, and what do people want to do? They want to do what? Give benzos or give meds? Is that what I'm hearing? Perfect. So we want to give some, pick your medicine, Ativan, diazepam, whatever it is, right? What is the action, what is the time of onset for, say, lorazepam? IV. Does anybody know what its onset, time of onset is? It's about 3 minutes, 3 to 5 minutes. So by the time your medicine, someone's ran and got the medicine, come and given the medicine IV, and the seizure stops, you push the medicine, the seizure stops, everyone's high-fiving, I just saved a life. Did the benzo you give them stop the seizure? No. And that's a very important point. It doesn't mean that you shouldn't give benzos. It just means you should think about why you're giving the benzo and what the clinical scenario is, right? So if it's someone who's a first-time seizure, or you don't know anything about it, well, maybe, and you're watching the seizure that's there, maybe you wait and see what happens. Or let's say it's a person with epilepsy. Like, we know they have seizures, they just haven't been taking their medicines, and they had a seizure. When you give that benzo right there, the only thing you've really done, to a certain extent, is prolonged the time until you can see a normal neuro exam. You might have confused it. Now, if they've had multiple seizures, they already seized once in the community, now they seized again in front of you, or if you're starting to get towards what we're talking about, where they didn't recover, that's when you want to start get aggressive with your seizure medications. But I digress a little bit. So what is refractory status? It's when you have the definition of status, seizure, right? So greater than 5 minutes or 2 within 30 minutes without returning to baseline, and it doesn't respond to anti-seizure medications administered in appropriate doses and routes. And what does that typically look like? That's usually you've given your first appropriate round of dose of a benzo, and often you started to give your first dose of that longer acting IV medication like phenytoin, fosphenytoin, Keppra, or levetiracetam. So like we said, IV benzo followed by a longer acting medication. So that's what refractory is, and so that's what we were asked to talk about. So why does refractory status happen? About 20% of it's infection, and for you folks in sub-Saharan Africa, it's probably a higher percentage. This is all seizures and all data that's out there, but seizure and epilepsy in sub-Saharan Africa and in Latin America, one of the bigger proportions is actually from previous infection or current infection. And so I suspect refractory status is going to be a higher percentage from infection in your setting. Stroke is another reason. About 15% is stroke. Anoxic brain injury, so folks who have had and suffered anoxic brain injury who now suffer from epilepsy can have refractory seizure. A big one is seizure medication withdrawal. So if there's someone who is, say, on 3 different seizure medications, and then they end up in jail or something like this, and they come in seizing, that person is going to be a whole lot harder to stop their seizure than the average person, right? And tumor obviously can do it, so if you see refractory, trauma can do it. But the funny thing here is the biggest group, at least of overall worldwide data, is cryptogenic. We don't know why it happens. And it just refractory seizure will happen. Then we treat it with our medications, which ends up being a ton of sedation, as we'll talk about. And then we slowly take our foot off the sedation and just hope they don't seize again. And then we start to do our workup as to why they have it, correct the things we can correct, and then move on from there. Maybe they need to be on seizure meds. So how to manage seizures, I said it's not Seizure 101, but we'll put some stuff in here. Basic airway stuff, right? So airway, patient positioning, monitor, oxygen, suction. These are things we do with every seizure. Check a glucose, right? This is one of those things, we all know it when we sit in the classroom, but invariably when the patient's in front of us, somehow it can be so hard to remember to check a glucose. But it's one of the simplest, easiest correctable things that we should be doing in a patient who shows up seizing. Get access. Getting access on a seizing patient can be very difficult, right? If they're sitting there having a tonic-clonic seizure in front of you, it can be extremely difficult to have access to their arms. And so if they've been seizing, now we said, we got to wait till 5 minutes and we're going to call it a status seizure. Are there other ways we can deliver medications? Sure, how? IM, so we could give them some IM benzos. And if we needed access, maybe we consider it an IO, right? And so I'd be moving earlier if someone who is going on 5 minutes of seizing, which if they present seizing and someone brought them to you, it's been more than 5 minutes. What patient in the history of anywhere, other than they happen to be visiting their friend in the hospital, starts their process that quickly, right? So if they come from the community in seizure, they've probably been seizing for 20 minutes, longer, right, before they've come to you. And that person you need to be extremely aggressive with. That's someone I would probably be giving IM and drilling, if I have the capability of getting an IO, putting an IO in and being very aggressive with my medications. Of course, we're going to check basic labs, right? We want to think about sodium. We want to think about pregnancy, right? A woman who's seizing and is pregnant is a whole different thing, right? And our treatment is different. We start thinking about eclampsia, right? And the treatment for eclampsia is magnesium, which is not in your standard algorithm for seizure, right? Nowhere in the normal seizure is it magnesium, only in pregnancy. So you really need to rule that out. Now, most women who are seizing eclamptic do you remember how many weeks you got to be? 20? I think I heard someone whisper 20. We're a silent group. Yeah, so usually eclampsia and preeclampsia aren't going to occur before 20 weeks, right? And so after 20 weeks, remember we usually can feel the uterus at the belly button, right? That's about the discerning point. We can start to feel the fundus at the umbilicus. And so if you're more gravid than that, sometimes you can tell. But I'll tell you, I've had patients that nobody knew they were pregnant. The patient themselves didn't even know they were pregnant and were well into 30-week territory. So that is a possibility and something to think about. And then get history if you can, right? If the cousin shows up and is like, oh yeah, that's my cousin Jeff, he's got seizures. Be like, oh, problem solved. That's a whole lot easier than I have no idea why this person is seizing. Okay, so we've got our prolonged seizure or second seizure, not a baseline. First thing you want to do is recognize this is likely different, right? This is one where you're being like, I might need some friends. I might need some help here. I'm going to need a team of folks. I'm going to need my nursing colleagues. We're going to need IV lines. We're going to need medications. And if this keeps going, what's going to happen? And you want to be thinking about that real early on, right? Like if you work at a district hospital or somewhere, a lower level facility, you might be thinking about trying to arrange for transport. Not saying you want to just throw them in an ambulance seizing, but thinking about after I get done doing what I'm going to do, this person can't stay here, right? Because ultimately if someone keeps seizing, what do you keep doing? What do you guys think? Do you watch them seize and hold your hands? Or do you just keep pushing drugs? Drugs. And so that becomes the issue. And so we give a second dose of benzo, and then we can think about our longer acting seizure meds like phospheny, phenytoin, valproate, Keppra, and think about your next steps. So maybe if you're lucky you have a lab to correct, right? So maybe they're hypoglycemic. Perfect, give them some glucose. That helps our situation. You want to ensure that you have status dosing of your meds, so they're standard dosing of maybe you'd give phospheny at 18 per kilo in like trauma or something like that to prevent seizures. But in status, you can push that upwards closer to 30. And if we're talking about Keppra or levetiracetam, it's 4 grams instead of 2. And so you have room. Make sure you check your resources. I'm not a huge fan of remembering drug doses, especially ones I don't use on a regular basis. And so I want to have a place to look this up. And the good news is, at the end of this, I'm going to show you and give you a free resource that you can QR and have on your phone, so you don't have to remember anything I said other than that you can pull up the app, okay? That's probably smarter than me anyway. Start calling your friends if you have them, right? So in my setting, if I have refractory status, this is something that I'm going to end up likely doing high-dose sedation that's going to likely require propofol or midazolam drip. They're going to be so sleepy, they're likely going to end up intubated. And then once they're intubated, then you might want continuous EEG monitoring if that were available. That would be sort of the end piece here. And you basically just give drugs until you see the EEG stop seizing. Does that make sense? And that's how you would monitor it. That's sort of the gold standard for where we'd head. So as I said, you can anticipate that as you give escalating doses of benzodiazepine sedating medicines, it doesn't take a rocket scientist to know your patient's going to be sleepy, right? Like that's what happens when you keep giving benzos, you keep giving propofol, your patient's going to get sleepy. We talked about then thinking about EEG or the need for transfer. Start thinking about those things early. If you give your second dose of benzo and you hang your phenytoin and the patient stops seizing, and they're doing okay, they're sedate, but they're maintaining their airway, great, hallelujah, right? But if it continues that you have to continue giving more medicines, then you know that patient's likely going to need airway management and likely going to need to be transferred away from where you are, depending on your resources. So what comes next? Like I said, so you've given your first dose of benzo, it's not going well, you've given a second dose of benzo, and you said, please go get me some phospheny, and we're going to give them that loading dose, and we've given the loading dose, and these things can take long periods of time. Their onset of action is even longer, right? So if you're waiting for your phospheny to be stopping the seizure, you're minutes into this process, which means you need your short-acting drugs to be more aggressive, right? So that's whatever you have, whether it's Ativan, whether it's midazolam drip, or whether it's propofol, or whether it's a barb, right? A barbiturate, and we'll talk about those in a second. So the truth is, I don't think there's any right or wrong drug. There are only choosing between what you have and what your resources are, and what the expected side effects are going to be. Right? So if all you have is a barbiturate at your setup and you don't have tons of benzos, or you can't do a midazolam drip or a propofol drip, then you're going to use a barb. But barbs do they have long half-lives, or do they have short half-lives? Very long. So do these people who have refractory status, do you think that we are going to use a lot of drugs or a little drugs? A lot of drugs. A lot of barbiturates. Are these people going to be awake and smiley, or are they going to be sleepy? Super sleepy. So now you have a super sleepy patient who's not really protecting their airway for a long period of time. That's why you can start to see that barbiturates aren't always the best choice if you have a choice. But maybe you don't have a choice. So let's talk about drugs. There's little overwhelming data. The consensus in most of the guidelines is they like midazolam, they're over propofol, and they like propofol over your barbs, okay? The reason the barbs are at the end of the list is for what I just talked about. They last so long, and usually by the time you get to the dose you need to get what they call burst suppression, meaning you stop the seizure, they're so sedate, they're sedate for a long period of time. This creates increased ventilator time, increased ventilator-associated injuries, and poor resource management. So if you can use midazolam and propofol, they're much quicker on and they're much quicker off, and that's why we like them. They like to make the argument that midazolam has fewer hemodynamic effects. I think at high doses, any of these drugs are going to cause along with sedation, hypotension and other hemodynamic effects. And certainly we know propofol does, right? Propofol at high doses, it is a common effect that if you give 1 to 2 per kilo, if you give 1 per kilo of propofol, you're often going to drop that patient's blood pressure, and that's often where you're starting and then keeping them on a drip. So anticipating that is helpful, and we'll talk about that. So we talked about midazolam and propofol and how they have short half-lives. Prop is quicker off, right? You turn propofol off and patients will wake up within a few minutes, right? Midazolam still is going to be quite some time before they'll wake up. Less vent time. Midazolam may have less hemodynamic effects, but I'm not completely convinced, but that's what they like. Bolus followed by drip and then additional boluses. You can look up the doses and I'll show you where. If that's not working, then add propofol or a barb on top, right? So say you started with midazolam and that's the route you chose to go, and it's not working, and you've maximized your doses of your long-acting seizure medications, then you can add other medications like prop or the barbs. We talked about barbs being a little slower, longer half-life, and it will also cause hypotension. So here's an interesting new one, right? Ketamine. And this is one that there's not as much data, or there's very little data, especially in refractory status, but ketamine is being used more and more after we've maximized our initial therapy. I wouldn't use it for my first line management, but when you have someone who you've already given essentially a maximum amount of midazolam and you've put them on, say, phenytoin, you're likely to have the returns of giving more benzos becomes less and less and less. I mean, at a certain point, you will have saturated all those GABA receptors, right? And so once you've done that, giving more doesn't necessarily get you any more blocking of your seizure. It just gives you more of the harmful side effects. So you're going to have increasing sedation and increasing hypoventilation and hypotension without so much benefit of controlling seizure. So how does the theory on why ketamine works? Ketamine is an NMDA antagonist. It blocks glutamate from blocks glutamate, and glutamate is neuroexcitatory. So the thought is, when you've already maximized the effect of using your GABA drugs, like your benzos, giving more won't help, and giving more drugs that act in a similar fashion won't help. Let's try doing something else, like adding ketamine and blocking neuroexcitatory glutamate, and that's how it's thought to work. So helpful when you've already maxed out your GABA antagonists. So hypotension is going to occur. So just assume that if you're giving high doses, that you just need to assume that they're going to get hypotensive. If you already know they're going to get hypotensive, you should be thinking about this earlier on. When you're getting to that second dose of benzo, I'm already starting to think about, okay, man, if I have to keep going with this, I better figure out what my pressure situation is now, which would start with pump function. I would grab my ultrasound and I would say, does their heart work good, heart work bad? Then I would come down and try and look at their IVC. IVC full, IVC not full. I would maximize my fluid, my volume status, and then if you're able, if you're doing high dose benzos or if you're getting to high dose barbs, you are likely going to need to do a lot of blood pressure management. If you can do an arterial line, that's going to be helpful. Often these patients end up on norepinephrine or noradrenaline because of the effects. And this is a common situation where you're using both high-dose propofol, but then you're using norepinephrine to counter the known fact that they're going to get hypotensive. You can use norepinephrine peripherally as long as you have a good 18 gauge. It's not ideal, but if you're starting and your patient is hypotensive, start that way, and then if you're able to move to a central access later, that is preferred. Okay, you know, when these folks get sleepy, obviously the ideal situation is that you intubate them. It protects their airway, it takes one more problem off. But the truth is, we can't always intubate someone wherever we are. And even if we could intubate them, maintaining an intubation, I mean, intubation is easy. Anybody can push drugs, look in the hole, stick a tube. Now what? You know, do you have a vent? Who's going to monitor the vent? It's very resource intensive, and how do we transfer them? And so, and sometimes it's just not possible, given our patient population, ability to pay, you know, disposition, etc. We know that this gets challenging. So does that mean you'd say, well, I'm just going to stop giving more benzos. I'm just going to let you seize, because if I give you more, I'm worried I'll have to intubate you. So I guess I'll just let you seize, right? Like you can't do that. So you might be in a situation where you are, as we say, you're on a tightrope, right? You're giving more benzos, and you're going to watch that airway real closely. So things you could do, waveform capnography to see if they're actually breathing, oxygenate them, head of the bed elevation to protect their airway. Now, if they get so sedate, you're going to have to start thinking about bagging somebody, right? But if you're bagging someone like that, that is going to eventually end poorly, right? They are eventually going to fill their stomach with air. They're eventually going to vomit. It's not a definitive airway. It's not an ideal situation. But we end up in non-ideal situations often, right? Obviously, think about suction. You could think about airway adjuncts, LMA or some other thing, but this would not be ideal, right? This would not be an ideal situation to say, I'm going to sedate you to the point that I should intubate you, but I can't intubate you, so I'm just going to use an LMA. That's not gold standard. It's just, if you force me, if I have to give that many benzos to stop this seizure, you may be forced into that position. So here we go. This is starting to look algorithmic, right? So how do I remember all the steps? You could look at this sort of thing. I put it in there so you have it in the slide deck, but this is up-to-date algorithm, right? So this has like every dose, everything as it might look. But I don't know about you, but many of us don't have up-to-date on our phone. But you know what you could have? Has anybody seen this before? Do you guys know what this is? This is the EMFK, the Emergency Medicine Foundation Kenya's algorithms. If you don't know about this, I will show you. You can get your phone ready and you can get the QR code in a second. They have algorithms for most emergencies. They have them for both high resource and for rural settings that are free downloadable. They have basically every topic under the sun, everything from a cardiac arrest algorithm to laryngitis and upper GI bleed to stroke to poisoning. So for those of you who are setting up your own emergency department somewhere and need help with safe guidance on how to take care of your patients, this exists. And they've made it into a fancy app that is free that you can download on your phone, and it has all of the algorithms on your phone that you can take with you. And I'll leave that up and just say, I would normally ask for questions, but I'll be done. So I'll just leave this up for those of you who want to get it. And that's all I have to say, guys. I'm done. Thank you very much.
Thank you so much, Steve, for that wonderful and nicely presented topic on status epilepticus. I hope people here understand and got it, like PowerSafe and anti-malarials are not the mainstay management of conversions. It's done so much on periphery. You keep asking people, what did you do for this kid who is conversing? We gave ceftriaxone, we gave antimalarials, and that's it. Thank you so much. So I'm up here introducing our next speaker. Our next speaker is Dr. Ismail Sangay. I'm humbled to introduce him to you. Dr. Ismail Sangay is emergency physician who worked for over a decade at the Sri Hindu Mandal Hospital as the head of department of, it's called critical care department, which comes in a package of 3. So it's emergency, HDU, and ICU, right? And I just want to say Dr. Ismail Sangay is one of the first big brothers, our giants in emergency medicine. We have grown under his wings, mentored and taught. Up to date, when I see DKA in anything, the first thing comes in my mind is Sangay, because he was the first one who introduced us, most of us, to how to manage DKA and how long it takes before you admit the patient to the ward, which was amazing. Thank you so much. Today he is going to give us a lecture on the topic, use of oxygen. Libero versus conservative, benefits vis-a-vis harm. Welcome everyone. Thank you.
Thank you for the warm welcome. I don't sound like a giant. I'm very tiny. Though I was one of the batch of the emergency physician. Thank you for welcoming me, and this will be, I think, the last talk. I think we may not do the stretch part because everyone might be tired. So can we have the slide? So my talk will be on, My talk will be on oxygen updates, depending on what you see at oxygen, as your friend or as a foe. I think during the COVID time, we'd used so much of oxygen. I think that was the most used oxygen, not only in Tanzania, around the world. So I just came to know recently that it's not only the friend that we know, but it's also a foe. Basically, why we need an oxygen? We need it for survival. And if we go back to our physiology or biochemistry, when in the presence of oxygen, we produce good amount of energy. But in the absence, we have a small amount of energy which can produce. But if you look into that, like it has to transport to a series of equations. Don't worry about this whole series of equations because even I don't remember those. Just focus on this three part: delivery, uptake, and then extraction. So just to summarize, how oxygen transport works. It has to bind 4 molecules for each hemoglobin molecule. That's why we end up getting SpO2 of 100%. Then the cell uptakes about 25% of it. And the return comes back to 75, which we end up calling central venous oxygen. So to summarize further, so the delivery of oxygen, it's approximately a liter, which runs around in a minute, ends up uptake to about 25%, and as I said, to 75% goes back, and the whole cycle continues. So what is hypoxia and hypoxemia? So oxygen is usually required by our cells, tissue, and organ. Our oxygen and hypoxia and hypoxemia are the same. Unfortunately, it has been used interchangeably, whereby hypoxia and hypoxemia are not the same. Patient may have hypoxemia without hypoxia, but hypoxia to develop, hypoxemia has to be there. There are 4 major mechanisms whereby you end up getting hypoxemia. One is decreased of oxygenation, which usually happens if the patient is on influence of some of the drugs, CNS pathologies. Other one is alveolar hypoventilation, could be pneumonia, ARDS, or fibrosis. And other is pulmonary embolism, COPD, due to diffusion abnormalities. And last is right to left shunt, can be either anatomical or physiological. So then, what's the goal of putting a person on supplemental oxygen? Is to correct hypoxemia and decrease work of breathing. Back in the days whereby we never had any clinical trials, so this was the set target were set in somewhere in 1970s and 80s, whereby they set a goal that a patient, we have to meet a target of more than 60 millimeters of mercury, or in terms of SpO2, saturations above 90, assuming the patient had a normal hemoglobin. Now, this does not apply for all the patients, except for the patients who are hypercapnic. Their levels will be on the lower side. Sets can be 88 to 90%. So since we should be on the same page, I'll be using so much of FiO2, FiO2, FiO2. FiO2 means fraction of inspired oxygen. At the room air, what we are breathing in, it's about 21%. And as a simple rule which I learned back in the days, for every liter of oxygen which we add up at least 4% of extra oxygen. So if we're talking about oxygen delivery, oxygen is a gas. You can't just grab the gas in the atmosphere and provide the patient. So you have to give with the devices. So we have like two systems, low flow and high flow, or low flow open system and closed system. So open system can be from nasal prong, mask, non-rebreather. Unlike the closed system can be from venturi mask to CPAP, high flow to invasive ventilation. Now, talking about so much about delivery oxygens, we have to understand the physics. As we are on the sea level, I know ARUSHA, we are at least 1,500 meter above sea level. So we are exerted a couple of pressures on us. It's just approximately 1 atmosphere, and you can use any units possible. So it's the pressure which is exerted. We feel comfortable, that's the push of oxygen comes in. So that's basically governed by one of the basic law which we learned in our school, Henry's law, which says pressure is directly proportional to the amount of gas or solubility of the gas into the circulation. So it doesn't matter how much oxygen you give, it matters how much pressure you deliver to push that oxygen into the circulation. So talking about further on oxygen, how much the tissue requires it. Actually, the small tissue to the cell requires a small amount of oxygen. If you look at the cascade, coming from 760 millimeter of mercury, when it touches down to our airway, it starts to 160s, goes to alveolar gas 190, to the cell 5 millimeters of mercury. It's basically a teaspoon of oxygen which our cells do require. And from the physiological studies, it was seen that our cells require a very small amount of oxygen to take aerobic metabolism. We all know our normals are 70 to 100. If you end up seeing this, our brain just requires about 24, till the lens just 1 millimeters of mercury. Since we more talked about so much of the oxygen, oxygen has its dark sides. Like any other drug, oxygen is also a drug. When appropriately used, it is extremely beneficial. When misused or abused, it is potentially harmful. So talking about the hyperoxia, it has several clinical consequences. From CNS, can end up causing seizures, coma, and it has been noted even in neonates causing retinal damage. And we are used to giving too much of oxygen during the COVIDs. We ended up seeing further worsening of the alveolar and ending up causing ARDS by washing out the surfactants and leading to absorption atelectasis. So how oxygen toxicity do happen? That's all because of oxygen stress. It's an imbalance between oxidant and antioxidant. What it does, that's higher activity of oxidation compared to the antioxidant. So what are those? Oxidants and antioxidants. Like as any drug, oxygen has to go its metabolism, and in the mitochondria, it has to form a tiny molecule, a cepha compound, and this has been assisted by the antioxidants, by several enzymes that are supported by many cofactors from iron, selenium, and we might have been prescribing during our COVID time an ample of vitamin C, zinc, selenium, and so forth. So these are the few of the antioxidants that can support or inhibit, or I would say, new topics against the oxidants. So what FiO2 can be toxic? From the observational studies, it has been found that if given 100% of oxygen for more than 12 hours, it can be toxic. 80% for more than 24 can be toxic, and even 60% if given more than 36 hours. There was just a recent study during the trauma. Many of the trauma patients, they ended up getting oxygen. They observed that more than, if patient received more than 60% of oxygen for more than 2 hours, they ended up getting higher mortality compared to those patients who did not receive oxygen. So talking about oxygen, even the room air which we are breathing can be toxic if a patient does not have enough antioxidant stores. Just giving an example, if you peel a potato or an apple and keep it exposed to the air, it will turn brown, and compared to it's not peeled. So the unpeeled potato or the apple has a property of antioxidation compared to the peeled one. So that ends up causing oxygen stress. So how much is too much? So there had been several trials which took place for the past 10 to 15 years, yet there had been no any clear-cut consensus, as they did not use super optimal amount of oxygen during the trial, which is more than 150 millimeters of mercury. However, there were just 3 studies which were done in this past 10 years. One of them was in the ICU, somewhere 2016, though it got halted. They used about 150 millimeters of mercury as a target, which found that it was more inferior compared to those patients who were on the conservative side. Even there was a trial done in the terms of STEMI. Back in the days, even I learned that if a patient comes with an MI, there was a mnemonic that we learned, MONA, morphine, oxygen, nitrates, aspirin. Apparently, giving oxygen to those patients who were normoxemic ended up causing larger infarct sizes. And there was another third study done in 2017. It's a sepsis trial. They thought like, okay, the lactate levels were so high that that's because of too much of anaerobic. There might be the cells were not getting enough oxygen. So they started pushing 100% of oxygen for at least 24 hours. What they found out? They found out that those poor patients who received more than 100% led to higher mortality compared to those patients who did not receive that amount of oxygen. So coming to the systemic review and meta-analysis, looking at the bigger picture. So they took about 25 clinical trials looking into what would be the goal. Should we think of liberally giving oxygen or conservative? So for the 25 trials, they looked into it. Liberal oxygen therapy increased mortality without improving any other patient outcome. However, the authors support the conservative administrative of oxygen. There was another meta-analysis which was done on the post-cardiac arrest care. Apparently, they took about 9 trials, included 2,000 patients. In this trial, there were no any differences whether the patient received conservative or liberal oxygen. Now, so since we talked about so much about oxygen, so what's the current recommendation target? There had been so many society guidelines talking about oxygen from WHO, BMJ, American Society. They have put a target somewhere about 94 to 96%, and for hypercapnic somewhere about 88 to 92, except for American Thoracic Society, they're still thinking about it. Out of all these societies, only one of the society, they thought of patients with stroke and MI, not to give them oxygen if they are normoxemic, as long as their saturations are above 90%. If they are less than 90%, they can receive oxygen. So what next? So there will be some future trials to know or to address what would be the set target as to minimize organ injury. Let's see in the coming future and see, are we supposed to target the 94 to 96% as our target. So in the meantime, avoid excess use of oxygen if the stats are 93 above, because the goal is to minimize FiO2 and to adequately tissue oxygenate and to create a balance between delivery and uptake. However, you can supplement oxygen in some certain situation if someone having carbon monoxide poisoning, PE, or pneumothorax. With that, I would say asante sana. Thank you for listening. Any questions?
Thank you so much, Dr. Sangay, for that wonderful presentation. So we are going to make a little tiny change in the timetable. So we have one abstract guy, Dr. Suleiman Rashid. I'm going to call you up the stand. So Dr. Suleiman Rashid, he is a new general surgeon based in Pemba Island in Zanzibar. He is going to present his abstract. He is passionate about emergency surgery and providing quality surgeries to the undeserved. So before he starts, I would just want to ask a question from emergency medicine people here. How many of you kind of get into fights with surgeons when you call them to do something? It's like they don't get the concept of emergency surgeries. So thank you for being there, and probably you're going to be the our ambassador to kind of take this forward. We love you guys and we want to save lives together. Thank you. Karibu sana.
Thank you. Thank you for welcoming me here. Yes, I want to present my thesis with the title Modified Shock Index as a predictor of early outcome among trauma patients admitted at Bugando Medical Center, Mwanza, Tanzania. I am Suleiman as a principal investigator, and my supervisors, Dr. Vihari Kotecha, who is the senior lecturer and the consultant surgeon at the Bugando Medical Center and the Catholic University of Health and Allied Science. And another supervisor was Dr. Ali Akrabio, who is here, who is an emergency physician and the lecturer at Bugando. So you are welcome. So I will take you through all of this from definition to conclusion and the recommendation. But first, you need to understand what we mean when say modified shock index. In this study, modified shock index we defined as ratio of heart rate and the mean arterial pressure, which is calculated on admission at the emergency department of Bugando Medical Center. And the adult trauma patient in our study, we defined as any patient who aged 18 years and above, who sustained any physical injury with a Kampala trauma score of either moderate or severe. And the early outcome of our study was within 24 hours need for emergency surgery, need for ICU admission, need for blood transfusion, and mortality. Yes, trauma is a common cause. Trauma is continue to be major public health problem worldwide and contribute to significant morbidity and mortality, especially in young population. And more than 90% of these trauma-related injuries occur in low middle-income countries. and among all continents, Africa have highest burden of this trauma-related injury. And Tanzania, of course, is not far from this reality as among of low middle-income countries. Study from Bugando by Charlie et al. And Guillaume et al. And recently published a study by Sister Angelo. They found that trauma is among the common cause of admission at the Bugando Medical Center, and it contributed to significant morbidity and mortality. All these trauma patients are treated according to ATLS of American College of Surgeons, and there is a number of triaging tools that can be used to pick patient with a certain level or certain severity of injury, and that can predict their outcome. But these triaging tools, sometimes it is difficult, especially in emergency situation, because some of them they need some mathematical calculation, some they need investigation, so become difficult to apply in emergency situation. And in our setting, we have no reliable triaging tool that we used for triaging this patient. We are just using vital sign alone to check, to triage the patient. But study have shown that vital sign alone, they are inexact in determining or in predicting outcome of a trauma patient. But there is modified shock index, which is simple and a valid tool, which can be used in trauma to predict the outcome. So this study aimed to determine if modified shock index can be used to predict the outcome of a trauma patient in Bugando Medical Center. Problem was the burden of trauma in our setting, and we had shortage of blood in blood bank. We had a limited number of ICU beds, especially for surgical patients. And we are using vital sign alone for triaging of this trauma patient. And we are not considering a modified shock indexes can be used to predict the outcome of this trauma patient. So study to evaluate modified shock indexes as a predictor of outcome was highly needed. And the result of this study, we expect that it can help to predict the outcome of a trauma patient. It might help for preparedness of, and perhaps to have emergency blood bank at an emergency department. Also to have extra ICU bed for this trauma patient. Also, we can use modified shock index for quick sorting of this trauma patient and prioritizing for their ICU admission, blood transfusion, and emergency surgical intervention. We had 3 specific objectives. One was to determine the shock level by modified shock index among our trauma patient in Bugando Medical Center. We had the objective of looking for outcome of a trauma patient at the Bugando Medical Center, and to look for association between modified shock index and within 24 hours outcome of this trauma patient. This was the observational prospective study of all adult trauma patients admitted at the Bugando Medical Center from January to May 2013. And the study was carried out at the emergency department, ICU, and all surgical wards of Bugando Medical Center. We calculated sample size by using Zeman et al., and we found minimum sample size required was 185. We recruited participants at the emergency department of Bugando Medical Center, and we measure severity of injury of this trauma patient by using Kampala Trauma Score 2. Cardiac monitor were used to record the heart rate and the mean arterial pressure. Also, we calculated modified shock index at the emergency department, and we recorded it. And we followed the patient for 24 hours. we used the starter version 15.0 to analyze this data, and the p-value of 0.05 we considered as a significance for association. Also, we get permission from ethical body of Bugando Medical Center, and we provide informed consent and translated informed consent to all the participants. And this was our variable. Independent variable was sex, age, residency, occupation, referral starter, fluid starter, timing of injury to arrival to emergency department, mechanism of injury, type of injury, body region with the injury, severity of injury by using Kampala Trauma Score 2, hemodynamic starter including respiration rate, heart rate, mean arterial pressure, and modified shock index. And this was our result. So we recruited 188 participants, and so we recruited 188 participants. What? Yes, we recruited 188 participants, and almost 73% of our participants were aged less than 40, making median age of 33.4, and 80% of our participants were male, with the male to female ratio of 7.71. And almost many of our participants, they come from urban area, making 73%. And road traffic accident we found as a common cause of injury, making 77%. In determining the shock level of our participants, we found that almost 70% of our participants came with a high modified shock index, meaning that they have a certain level of a shock, despite of they are coming as a referral case. And determining the outcome of our participants, we found that almost 56% of our participants, they need blood transfusion. 10% of our participants die within 24 hours in Bugando Medical Center. And emergency surgical intervention, it needed in almost 62% of our participants. And the ICU admission was 23% of all trauma patients admitted at the Bugando Medical Center. And we look for some predictor of our outcome, and we found that severity of injury by Kampala Trauma Score was a significant predictor of ICU admission. Yes, we found that severity of injury was a predictor of ICU admission with a p-value of less than 0.001. Also, we found that ICU admission, need for emergency surgical intervention as a predictor for mortality among these patients who were enrolled in this study. Also, we found that need for emergency surgery is a predictor, or blood transfusion was more needed in those patients who underwent emergency surgery. We failed to get predictor for surgical for need for emergency surgical intervention, but by using Pearson chi-square test, we found that the need for emergency surgical intervention, it depends with the type of injury. In determining association between modified shock index and the outcome of our participant, we found that after univariate analysis, we performed multivariate analysis to remove all confounding effect of other predictors, and we found that those patients with high modified shock index was 3.44 times more likely to need blood transfusion, and those patients who have high modified shock index were 4.21 times more likely to need ICU admission, and those patients with the high modified shock index was 2.8 times more likely to need ICU admission, more likely to die. So in our study to show that many of participants were in their third decade of life, and they are coming from urban area. This is similar to other study which reporting some same result. Also, that we found the common predictor of this, the common cause of this trauma was road traffic accident. The main reason of this is that we think because many of our participants, they come from urban area and they are unemployed, so they are likely to be involved in risky activity that predispose them from trauma. Also, as we see from many urban area, and a study from Uganda showed that in urban area there is increasing use of motorcycle with reckless riding and the negligence of road safety rule, that predisposing patient from man from this trauma-related injury. So this result, it make call for increasing law enforcement effort to prevent this trauma-related injury to these young people from urban area. Also in our study, we found that many of our participants, they come with the high modified shock index, meaning that they had a certain level of a shock. Unfortunately, we didn't categorize this shock according to ATLOS, but it is surprising because these patients, majority of them, they come from peripheral hospital, and from their record, it shows that they have resuscitated by giving IV fluid. So this result, we think, may be due to the presence of pain following injury, or inadequate resuscitation at the referral hospital, or ongoing bleeding from trauma site that cause a certain level of shock, which can present with the tachycardia and without hypotension, as we know how we calculated this modified shock index. So this is an alert to emergency service provider to increase effort on evaluating this patient and to increase and to manage them promptly in order to prevent them from mortality, because studies have shown that tachycardia increases risk of mortality even for those patients with who is non-hypotensive. Also in our study, we found that more than half of our participants require blood transfusion, making 56%. And the emergency surgery, patients who need emergency surgery was 2.8 times more likely to be transfused blood. This result is similar from what was reported from other study, but it differed from study which is performed in the same hospital by Charlie et al. Charlie et al., he found that the need for blood transfusion is only 1/3 of all cases, of surgical cases. But the difference, we think, because Charlie, he enrolled all patients who underwent surgery, either elective surgery or emergency surgery. And because this patient is the trauma patient, at some point we think they had a hemorrhage that caused them to need blood transfusion. And because trauma necessitates resuscitation by blood transfusion, and because many of these patients, they need emergency surgery, and it is a Bugando protocol that you need patient not to enter emergency theater without an HB of less than 10, with HB less than 10 or more, or to have blood on hand. So That's why we think the reason. Also in our study, we found that ICU admission was lower compared to that was reported by previous study in Bugando Medical Center. A study in Bugando Medical Center performed by Charlie et al., he found that need for emergency for ICU admission among among trauma patients was only 37%, and we found the need for ICU admission is 23%. This is because this study was performed more than a decade ago, and now in Bugando we have HDU room that make interim between general ward and the ICU. So this HDU maybe decreased the number of ICU admission. That's why we have a low number of ICU admission compared to what was reported by Chalia. Also, in our study, mortality rate was 10%. 10% is high compared to what was reported to the main study, which looked for 24 hours mortality among trauma patients. But also it is low from what was reported previous by Angelo. Sister Angelo, he performed a study on admission, hyperglycemia, and its association to outcome. And Angelo, he found that mortality was almost 30%. But this difference, it comes because we used the Kampala trauma score to look for severity of injury. And after scoring this, we obtain patients who are significantly have low Kampala trauma score, meaning that they had severe type of injury. Also the difference is Chalia, he followed patient for almost 3 months, and he recorded all this outcome, including mortality. So we think that was the reason of difference. So in our study, we found that modified shock index can be used to predict the ICU admission, ICU admission, need for blood transfusion, and mortality, like what we see from previous study. The limit of our study, we used quite low level of modified shock index. In conclusion, modified shock index can be used for early identification of patient at risk, and we recommend for routine record and use of modified shock index at emergency. Thank you.
Thank you. Thank you, Dr. Suleiman, for the presentation this afternoon. Ladies and gentlemen, we're almost getting to the end of our conferences. But you know what? We came to realize that for the past 2 days we were here, there was so much we learned, so much we put in our brains. So maybe we need to refresh it. And it will be nice if we get something from the mental health. It will be so badly if we go out without getting into this for us. So just bear with us. We have one presentation regarding mental health. And this is going to be just a few minutes before we're having our closing ceremony. And this will come from Dr. Anwar. Dr. Anwar, you're welcome to podium. Dr. Arnold is a child, adolescent, and adult psychiatrist. He graduated in 2013 from Midwestern University. And then he did his residence program in Washington University. He's passionate about decreasing stigma and improving access to quality mental health care. And today, he's going to share something on mental health program with the police traffic in ARUSHA. It's so interesting. Just, Dr. Arnold, you're welcome. So just to update you on the program, once Dr. Arnold will complete his presentation, then it will be time for question and answers. So only your question, just phrase it nicely, so we get a chance to ask it, all presenters who did this afternoon. And after answering all the questions and the comments, the next will be the closing ceremony. And this will be just a few minutes for SQF Foundations, the chairman and the team of organizing committee, just to say a word before we go after this conference. And apology on the timetable, we didn't allow the break in between because there was so much requests regarding people that need time to do networking, to exchange contact and all of that. So we decided we give more time after that. So once we have a closing ceremony, then we'll have a time for tea, networking until end of the day.
Thank you, everyone. Thank you for allowing me to speak for a few minutes about Kopi Medical's mental health program that we're running with the ARUSHA Traffic Police. As he introduced, my name is Ali Anwar. This is my second time in ARUSHA, and I'm really excited to tell you about our program tonight. So just to review, Kopi, we're a non-governmental organization based out of the United States in Minneapolis, Minnesota. We work on programs at the intersection of emergency medicine and mental health. Kopi's work in ARUSHA started originally in 2019, so this is our 5th year here in ARUSHA. So the mental health part of the Kopi's team consists of psychiatrists, psychiatric nurse practitioners, registered nurses, social workers, psychotherapists, and mental health counselors. So to talk a little bit about kind of what our goals and objectives are, what we find is that police officers often have repetitive exposures to traumatic events on the job. Specifically in Tanzania, the burden of traffic-related injuries and deaths can cause an increased level of stress and accompanying psychological symptoms. We have seen studies that have shown regular exposure to traumatic events can result in psychological symptoms such as depression, insomnia, post-traumatic stress, anger, and anxiety. So what we know is improved mental health coping among first responders can contribute to advances in the quality of care that is delivered on scene. Existing studies have shown that mental health can impact a job performance. Poor mental health can negatively impact one's job performance, making it extremely difficult to adequately complete one's duties. We also know that mental health has a positive impact on one's job performance, where mental well-being is directly correlated with a better impact on one's job. What we know is that in Tanzania, the mental health impact of responding to injuries has not been studied, so it's unknown to what extent the traffic police in this region specifically are affected. In looking at some studies that were done in the United States, there was a survey of 2,000 first responders. This included police, firefighters, as well as emergency medical personnel such as EMTs and paramedics. This showed that 85% at some point had experienced symptoms related to some kind of mental health conditions. Another study also found that depression and PTSD in the USA are 5 times more common in first responders, including police, firefighters, and EMTs, relative to the general population. So just a review of what PTSD or post-traumatic stress disorder is. So post-traumatic stress disorder is a condition that develops in some people who may have experienced a traumatic or frightening event. Examples of a traumatic event include a natural disaster, a serious accident, an assault, a terrorist attack, military combat, or anybody who's been threatened with death, sexual violence, or injury. The stress caused by witnessing or experiencing the trauma can affect any aspect of a person's life, including mental, emotional, and physical well-being. PTSD can cause a person to relive the past trauma in painful memories, recurring dreams, or nightmares. This may also result in a person avoiding activities, situations, or places that remind them of that traumatic event. And these PTSD symptoms can often coexist with other conditions such as substance use disorders, depression, and anxiety. This is directly from the World Health Organization. So in a previous study of 21 countries, there were more than 10% of people participating in the study reported violence, 21% experienced interpersonal violence, 17% accidents, 16% exposure to war, or 12% experience to trauma to a loved one. So what this showed is an estimated 3.6% of the world's population has suffered from PTSD in the previous year that this study was taken. So our mental health education program is informed by the World Health Organization's Psychological First Aid Guide for Field Workers. So the reasons to use psychological first aid are that studies that have been done on psychological first aid have shown that this can result in reduced symptoms of anxiety, depression, and post-traumatic stress. One advantage of psychological first aid is that it doesn't require specialist training, and it can be delivered by non-mental health care workers. And another advantage is that the psychological first aid protocol has already been translated into several different languages. So a little bit about our work so far. Our education that we've done is, again, informed by World Health Organization's PFA for field workers. The focus that what we've focused on so far has been psychoeducation of PTSD, the alarm response, taking care of oneself, and peer support. Basically, normalizing what a trauma response is to somebody who's experienced a recurring trauma. We've had skills stations involve discussions with first responders about previous experience of trauma that they have experienced. During some of our discussions, this has led to the sharing of traumatic memories that has elicited emotional response in the groups that we've trained. And we've always had mental health professionals on site to provide support. So to kind of going back to that point I had made earlier about there not being a study in first responders in Tanzania, so we're not sure to what extent specifically it impacts this population. What we did is trying to get an idea of how much it impacts the first responders within our groups. So to measure PTSD symptoms, we had each respondent complete the PCL-5, which is basically a 20-item instrument that screens for post-traumatic symptoms. Generalized anxiety, again, we used the GAD-7, and then for depression, we used the PHQ-9. And each of these were translated into Swahili and have a scoring system as to what could be needing an intervention or what could be considered above normal in a response. So the mental health program, our main objective essentially is to improve the well-being of police and first responders so they can perform the duties of their job effectively. So future considerations in our program is we want to work on ways that we can continue to support the mental health and well-being in first responders and healthcare workers with a formal curriculum. So this will involve, our continued work with assessing the needs of the population. And then another step forward that we wanted to work on was expanding the current program to also include crisis intervention skills for police when they respond to a mental health crisis in the community. This could be some skills on how to respond to somebody who may be experiencing a crisis where they're severely depressed, suicidal, or experiencing a manic or a psychotic episode. Just to finish off, thank you to everybody for just hearing about our program. We wanted to thank the ARUSHA Regional Traffic Police, the Same Qualities Foundation, COPI volunteers, Dr. Peter Mabula, Dr. Ruba Joshi, Dr. Stephen Dunlop, and Dr. Brandon Nettle. Thank you, everyone.
Thank you. Thank you, Dr. Arman, for the last talk. What you get during the first presentation. Maybe
invention of SpO2. So before patient using necessary muscles, if they use accessory muscles, then you'll end up giving oxygen. If they are not, then just consider yourself like, okay, you are back in 1950s or 1960s. At that time, there was no SpO2. SpO2, the small monitor started somewhere 1980s. Before that, they were never giving oxygen. The oxygen was just administered when a patient was in distress, and then they ended up getting supplemental oxygen. As time went on, we started losing our clinical skills and then relying on the machine. We started treating the machine and less the patient. Now coming on the resource limited. Now resource limited, that's the most positive part. Because in my practice, I don't give overzealous oxygen, whether the patient is in the emergency department, in the ward, or even the ICU. The minimum oxygen I would give and optimize higher pressure. So that's how my goals are, and had been really supportive, not from the COVID time, even till now.
Thank you, Ali. You can stand. I'm going to make my way to you.
My question goes to Dr. Steve. I've always I had a discussion with the Ops and Gang team pertaining to eclamptic patients. So when you have an eclamptic mother who is actively convulsing in front of you, will you start be using the benzodiazepine or start with the magnesium sulfate?
So you're, and in this patient, how pregnant are they?
So it could be at usually they'll come in their 30.
Okay,
30
so you're saying
weeks.
this is eclampsia. So I have a seizing, and do they have a history of seizure? So you're just saying, or is this run-of-the-mill eclampsia? I'm just wondering if you're painting me in a weird corner here.
Yeah,
this
provided if she had a seizure before or not. Now you're talking of an eclampsia.
Yeah, I mean, if she's hypertensive and it's eclampsia, the treatment 100% is magnesium, all day, every day. Now, is there benefit to giving benzodiazepine? Benzos can help seizures, so if your magnesium didn't work and you felt like you had maximized that therapy, and then the patient was still struggling with seizures, then I'd start to use other seizure medications. You know, as a general rule, benzos in babies are bad during their development, and as a general rule, if the baby's coming out, you don't want to have the drug to baby as well, but you also can't have a mom who's continuing to seize. There are also other long-acting medications, like your Keppra or other things that are safe during pregnancy, and so that's something you could think about. There is data that does head-to-head compare benzodiazepines to magnesium for treatment of eclamptic seizure, and magnesium is far superior. Does that answer your question?
Yeah, but the patient now is actively seizing right now.
Right. So your question is, is your question, if I have magnesium in one hand and a benzo in my other hand, what should I give? Magnesium. Okay, so you're saying, so the question, so it's a different question. Your question is, if I have benzo in my hand and magnesium's going to take 45 minutes to give, should I give benzos? Sure. But we should all understand here the standard of care for treatment of eclamptic seizure is magnesium. Now, if I had a delay in that treatment and this woman was seizing in front of me for a long period of time, yeah, and the seizure wasn't terminating, because most eclamptic seizures will self-terminate as well. But if they don't, you know, yeah, you better believe if I'm looking at my watch and I'm going on, you know, a couple of minutes, like I'm uncomfortable, and I say, please get me magnesium, and they say, yeah, we'll get it, it'll be here in 30 or 45 minutes, you better believe I'm giving benzos if that lady's still seizing. Does that answer the question?
Thank you, thank you. Any other question in the floor? while I'm not seeing any hand, I have my hand here. I just wanted to make a comment on the oxygen topic, and regarding what the previous participant asked. During COVID times, I don't know, some of you might have not known, but major of us on the front line, we came to appreciate how oxygen is a very expensive commodity, right? In the hospital, sometimes we would use all the oxygen, and I think at that point is when I learned to be rational. Like, oxygen is very expensive and hard to get. So be rational on when you're using it, to who and what benefit are you giving to that person. Don't just throw oxygen on everybody who walks in. Thank you. Anybody else before I move? I think we're going to end this session here. People are saying stop talking, but thank you for listening, and I think the presenters can come down to the floor. Thank you so much. I think we can clap for everyone since the morning. It has been a really great day today, and personally, I've been touched in a really great way. I'm glad I traveled from Dar es Salaam to Arusha for this. To kind of end our session with the closing ceremony, I'm going to call to the front the CEO of St. Qualities Foundation, the tall guy. Come on, come in front. I don't have your bio. So, and then Professor Ellen Weber, Ellen Bibi Weber. Middle name is Bibi. So thank you so much. And right away I'm gonna put the microphone down and have you continue. Thank you.
It looks like everyone is exhausted. So let me begin by thanking God for making this a possibility, as I said yesterday. And we have come to an end of much interesting conference, which was preceded by the workshops, as we all know. And I really like to take this time to thank the government of Tanzania through its Minister of Health for allowing many of you to come here, Minister of Local Government too, where district hostels and below level hostels, most of you guys come from there, as well as the Minister of Home Affairs for allowing the police officers, firefighters, and police from the investigation department to be, although they were not here, but the COP team is here, which has a ton of instructors. The workshops were going on at one of the hotels in town, and yesterday and today they were on the side rooms just behind us here. So we thank the government for that. And I would like to take this opportunity to thank the organizing committee. They did great work, and thank the speakers. All these groups, they depend on each other. If you have an organizing committee without speakers, then you are doomed. So I thank the participants for turning in, and the volunteers. We have a number of volunteers from when we started the workshops last week, for the ultrasound, for translators from the other side, for the COPs, and so on and so forth. And so I thank the media and the SKF media team that have been working around to make everything smoother. And I would like to thank the management of New Safari Hotel for hosting the police workshops, ARUSHA Medical Center for hosting the mental health workshop, Grand Melia for hosting all other workshops plus the conference itself. And we we have sponsors, and I think they are amongst us. We have BSV. I hope they are in here. We do thank them. MQR, Blink Internet, CSSC, they are represented. They supported over 32 participants from across the country. KCMC, they brought closer to 30 participants. And I really thank and appreciate all the health facilities where everyone else came from. Along with that, I would like to thank the international collaborators. We have the University of Minnesota, which a team of over 20 were here for the course of 2 weeks, running PLS, BLS, SLS, ultrasound with a team from Mayo Clinic, University of California, San Francisco, Bibi. She's the guest of honor, sitting on my right side here. Emory University, Brittany, Chidi, David, and University of Texas. Unfortunately, Kenneth is not here with us. He flew to Nairobi yesterday, and one of the workshop instructors got sick yesterday and was evacuated to Nairobi. And this afternoon was scheduled for surgery. And we ask each and every one of us to pray for her so that the surgery goes well and for a quick recovery. We thank Hennepin County, where Steve comes from, Kopi, which is represented by a number of delegates here. Australia have John and Rina. Rina actually came almost this morning. And yeah, and she's flying back, I think, tomorrow. So we really appreciate for your commitment to fly the way and come and join us this morning. University of Cape Town, South Africa, Petra, I think she's, yeah, there she is. Oh, KwaZulu Natal. Yeah, thank you so much for coming and for your speech, and that was fantastic. And so we thank each and everyone, and we really appreciate for your commitment. We really appreciate for whatever you did to make this a possibility. And so, because without you people, we could have never had this conference. And so with that, I would like to invite Bibi, karibu, ili uweze kuongea na wana mkutano. Karibu.
So I too want to thank all of the organizers, the team that has managed us all so well. The speakers were fabulous. The hotel did a nice job taking care of us with a very good lunch and very nice snacks. And most of all, and the speakers, really great talks. Most of all, I really want to thank those of you who, first of all, came to some of the workshops, stayed through them, and then even stayed on here. And those of you who are here today in this room at 4:30 and stuck with it the whole time, I think and I know you learned a lot. I learned a lot. And I just say that we need to do this again and again, and we need to take the opportunity, and again, this opportunity we're going to have after this closing ceremony to meet each other, to work with each other, to exchange contact information, and keep these bonds going, and so that we continue to build a community of people who care and work hard and deliver the best emergency care we can. Thank you.
Yes, so with those remarks, we'll move into award presentations as a little token to remember this conference. And so I'll first call the supporters, and I'd like to ask the organizing team members to get ready. The first in our list is Kopi, so I'd like to call the Kopi representative to come forward, and Bibi will be officiating this. So, yeah, so MQ, Photographers, please. MQR, BSV, let's do it quickly. CSSC, the University of Minnesota. I know Marianne and Sam are enjoying time in Serengeti. So Steve, those are your neighbors, your university. And a special award to Rina for taking her time all the way to support us. Next is to the speakers or presenters, and so I call David Grink from Emory, Britton Murray from Emory, John Botha from Australia, Pasco from Tanzania, and Donifat. Pasco, Nathan, copy. Okay, Nathan. So Nathan is next. With the due respect, may I ask Amanda to come and hand over the award to Ellen Weber, please. Benjamin Wachira, I'm not sure if he's still here. Oh yeah, Steve, I know you can do this. Yeah. Like 10. Gulshan Kimji from Zanzibar. Sam Eberson, he's in Serengeti, I think, right now, so Steve. And then Stephen Dunlop. Francis is Sakita, and so I know Frida is among us, so please come and collect on his on behalf. Happiness Rabiel. I'm not sure if Dr. Kerr is still here with us. Anyone from, okay. So Frida from KSMC, you'll also pick for Happiness Rabiel. And then Catherine Shari. Gimbo. Prosper Bashaka. So don't be surprised. Some have been speakers as well as organizing committee members. So Zainab, when I heard she presented through Zoom. So Gulshan, Professor Petra, Chidi. Is Chidi here? Okay, Brit. Ken, so Ken is not here. He's in Nairobi with Beck. So anyone to collect for Kenneth? Steve. How much kilos do you have for your we can redistribute the weight. Kuzeima. And next is Sangay. Alanwal. Ali. I don't see Al here, so Nathan. And next is the organizing committee. The members of the organizing committee who are available here is Ala Krabi, Farid Abdallah, Dr. Saidi Kilindimo, Dr. Felista, and I hope I've covered it all. So this marks the end. Yeah, oh, it's here. Yeah, so Nathan, please, for Ali. Yeah, he stepped out. Yeah. So that marks the end, the conclusion and closure of this conference. Once again, I thank you all, and you are welcome to stay in Arusha and Tanzania in general. Go wherever you want. We have the beautiful national parks, I think, across than any other country across the world. So you are welcome to go and enjoy for yourself. Other than that, we plan for the next conference and welcome you all. It will be held most likely here on January 16 and 17. So we wish you safe travel home. See you next year. Thank you.